of people joining, and already we're already getting a lot of excited people, 70 to the count and increasing. So let's start our session with the first question. Uh, Madam, there is these interesting terms which we have been used, which have been coming around. And could you just help us clarify the differences between the following type 1 diabetes, type 2 diabetes, most of us know, but then there's a type 1.5, LADA, MODI, neonatal diabetes, there's a type 3. There are so many of these complicated things. Could you just simplify it for us?
Yes, I think that's a very pertinent question to start off this interesting session. So at the outset, thank you, Dr. Arun, for inviting me to be a part of this august audience. And it's something very interesting, and I look forward to exchange of thoughts and ideas. So the first question is, what about the classification of diabetes? Now, we generally follow the American Diabetes Association, which gives us the classification of diabetes, which is plain simple classified as type 1, which is basically immune-mediated diabetes, which is insulin deficiency, absolute insulin deficiency. Type 2 is the normal variety of diabetes, which we see, which is the insulin-resistant variety, which we normally see in adult population. And the third type of diabetes is the secondary diabetes, which includes all genetic disorders, it includes monogenic disorders, it includes chemotherapy-mediated pancreatic disorders, endocrinopathies, drug-related. So multiple forms which all come under the secondary cause of diabetes. And fourth is gestational diabetes. Now, there are some variations which have come on, like what you talked about, the 1.5 type of diabetes. Now, this is basically autoimmune diabetes coming up in adults. So, which is called as a LADA, that is latent autoimmune diabetes of adults. So, essentially, LADA is something, synonymous with 1.5 type of diabetes, which is immune mediated, but a slow progressing diabetes, which is seen in the adult population. Now, the other ones was MODI, which is maturity onset diabetes of the young. And that typically comes up in the second, the third or fourth decade of life, typically after the age of 25 or so. It comes up with mild diabetes, but these are usually monogenic disorders, means there is a single gene mutation which accounts for diabetes. They usually have some pancreatic deficiency, but they are not like type 1. So they are usually have a strong family history of diabetes, but begin with mild diabetes, but over a period of time, they might go on to insulin. But essentially in the first few months to years, they are managed only with tablets. And in fact, some forms are so mild that they be on only dietary modifications or only medications lifestyle. Then the other variety which we talked about was
type 3.
Sorry?
Type 3. There's a type 3 and a type 3C.
Type 3C. So type 3 essentially refers to the secondary forms of diabetes, where we talked about, pancreatitis. So type 3C is pancreatic diabetes. So people who have chronic pancreatitis, calculous pancreatic disease, fibrocystic disease of the pancreas, and, cystic fibrosis, all secondary pancreatic diabetes come under type 3C. So actually, if you look at this 3A, B, C, D, E, F, G, H, I, it goes up to. But they are all forms of secondary diabetes. But type 3C specifically pertains to pancreatic diabetes. So, and then you have neonatal diabetes, which is again a monogenic form of diabetes. So that is usually seen in babies under the age of 1 year of life. So there also it is generally related to some mutations. Some common mutations are KCNJ mutations, ABCC mutations, which target against the islet cells. And these babies sometimes can have pancreatic developmental disorders, again genetic single gene disorders. And very rarely we can see autoimmune diabetes in babies, that is less than 1 year of age. So any neonatal diabetes, which is diabetes in children less than 1 year of age, that can also be a genetic form of some form of genetic mutation. So terminologies are different, but essentially we need to remember type 1, type 2, pancreatic diabetes or secondary diabetes, and some genetic syndromes also like Down syndrome, Turner syndrome, Klinefelter's, many other syndromes, they are also associated with diabetes, which comes in the secondary category. And one of the secondary is type 3C, which is specific pancreatic disease.
Pancreatic lesion related. Okay, that was a very extensive kind of a thing, which I want my junior residents and PG students to know that diabetes is not just only type 1 and type 2. There are many more things that we are expected to know. Nalini madam, I had a thing intriguing me from the biochemist point of view. When we teach our MBBS students, type 1 diabetes present to you in the emergency with diabetic ketoacidosis. That is the standard story that we are teaching our first MBBS students. What percentage of children actually present as DKA? And if it's not a very high percentage, then how do you actually start suspecting or detecting them? Hello?
Am I audible?
Yes, madam, audible.
Right. It's a very important question that you've asked, Dr. Arun, and thank you very much for having me here today. I'd say I'm a little unnerved looking at the numbers and then very happy to be here. So the question is, the percentage of individuals who present with DK, the numbers may not be so high. The numbers of DK itself is, the type 1 diabetes itself is very small. But then when you look at the blood sugar level, when an individual presents to an OPD with weakness, loss of weight of a short duration, or complaints such of osmotic symptoms like frequent urination, my child is eating a lot, is drinking a lot of water, still losing weight in a short duration of time, maybe in last 4 weeks, that the complaint duration will be usually very small. And when we evaluate, when we look at blood glucose levels are usually on a very higher side, usually more than 250, usually touching around 400. Very high blood glucose level always tells us of insulin deficiency. Insulin deficiency is marked by high glucose levels. And when we look at that particular blood glucose level in that particular age group child, why should the child have it? The question, the duration, the history, as well as the presentation and presenting blood glucose levels, all these point us towards diagnosis of type 2 diabetes. In addition to it, we have to ascertain the diagnosis. Very important to understand because type 1 diabetes, it has to be treated with insulin. So antibodies have to be tested. Dr. Ashna, do you have anything to say or add to this?
Dr. Archana, would you add something to it?
No, I agree with you completely, Dr. Nalini, that antibodies have to be tested. Very short duration of symptoms and presence of antibodies is what would be a pointer towards type 1 diabetes.
So as I understand that the kind of a story that we are teaching our MBBS students as all these students, all these type 1 patients present with DKA, and then we have a good chance to discuss ketone body synthesis. That really does not happen as much as it is flaunted in the textbooks, correct?
It happens often, but not as often, but it is very dramatic and life-threatening. The importance is it being life-threatening.
Okay.
That's the reason why we need to act on it. We need to consider even one single DK episode very important.
The one DK episode is very important, we understand, but the kind of a message going around is the first time type 1 diabetes is diagnosed is only as DKA. That statement is not true. And the patient present with osmotic symptoms. That's another important point which I need to share with. I need to share with all of them because our standard textbooks say that that's it.
Yes.
So they're present with osmotic symptoms, weight loss, increased urination, weakness, and when you do a sugar to them, then you tend to detect the presence of type 1
short
diabetes.
Short duration is very important.
The catch one is short duration in that.
Dr. Arun, can I just interrupt? So one point to understand is adolescents. So typically who present with type 1, they may not come with acidosis. They may just come with osmotic symptoms, weakness, but they may just have ketosis, but no acidosis. So if you're talking about that dramatic presentation of DKA, where a child has a small respiration and all those things, well, that is seen in a majority, no doubt about it. But we still typically adolescents, somewhere in the teenagers, a later onset of presentation, they may still come to you earlier in the hyperglycemic ketotic stage, but not in the acidotic stage. So we are seeing that. But younger children, in fact, neonates, babies, and toddlers, they can directly come with DKA. So that's probably a certain point.
Okay, so the older ones tend to survive a bit better. The younger ones would present more with the ketosis part.
They may present earlier. Instead of survival, probably we can put it that older ones may present with diabetic ketosis rather than growing up to full-blown acidosis, because they tell you about the symptoms, whereas the younger kids may not be able to tell you about the symptoms.
Great, thank you. Last time, ma'am, when we were talking, you used a word about glucotoxicity, and I then checked it up with a few of my friends, and they were not aware of it. So, could you just explain glucotoxicity to our people?
Right. Glucotoxicity is that toxic effect of glucose which impacts the beta cells. So beta cells get affected at multiple levels because of the prolonged high blood glucose levels, usually more than 250. What happens is that the beta cells may undergo oxidative damage, or there can be non-response of the translation and the transcription of the translation that happens usually to produce insulin. Insulin is a polypeptide, as you all know. So, and it is controlled at the level of translation. So translation process and the control becomes very stringent, and transcription to translation doesn't happen. Often it is even the cells going into more or less something called stunning. They go into a stunning phase, whereas because of this prolonged hyperglycemia, they are no longer able to produce insulin. So there is high glucose level. In response to it, we want more insulin, but here there is less insulin. So there is a vicious cycle which forms here, and this forms the basis of glucotoxicity and importance of understanding glucotoxicity here.
Thank you. Thank you very much. Suhas sir, I have some questions for you. And this question is two things. One is when we talk about the biochemistry, there are two enzymes, glucokinase and hexokinase, both of them used for glucose estimation. Do you find any difference between using any of these two techniques for estimating the blood glucose levels, plasma glucose levels? Is there any difference between these two enzymes?
You're muted.
So you're muted.
Thanks, Dr. Harit, for the kind introduction. Some cases we have found a variation in the hexokinase and the glucokinase. The preferred is the GOD-POD method, which is used universally. But in some instances, if you do it by hexokinase method, we'll get variations in the glucose levels. That is what we have found. As a lab, you can also point out what exactly the changes comes because of this methodology changes.
Okay, so by and large, GOD-POD is the one which would be commonly used in most of the labs. So it's better to
Right.
go with that. One more question before I take it with the clinicians. When we are doing the fasting and postprandial, what is the kind of pre-analytical errors that occur when we collect samples for fasting and postprandial? I mean, how many people actually give a proper fasting or a PP sample?
Usually the criteria for fasting is around 12 hours of fasting should be there, minimal. So some people will not follow the 12 hours of fast and give the sample in 10 hours or 11 hours. In that, the fasting values will vary. Even for postprandial, we need to find out from the time, like what we discussed, we see that some cases we consider the time from starting the meal. So what time you start the mill, that time you should consider as the time to calculate the cutoff or after you finish the lunch. So if you calculate the cutoff after you finish the lunch, then that is an ideal time to collect the post meal.
Oh,
So if you
I know, ma'am,
Sorry.
I'll come to you. I'll come to you.
Yes.
I know you wanted to answer that question. I'll come to you. My point is, chai biscuit is not considered as considered as fasting. Quite a bit of that, right?
No, not fasting. Fasting, though we are not
जनता चाय
taking.
बिस्कुट भी क्या जनता चाय
No.
बिस्कुट खा के भी आके बोलते हैं मैं तो फास्टिंग हूँ करके. So now the questions to Archana madam and Nalini madam are two things. One is what is the ideal time of postprandial? Is it 2 hours from the start of break from the start of meal or 2 hours after the end of meal? Because this is something which is intriguing.
Yeah, so actually, I found this is such a nice platform to share our thoughts, And as you said that we talk, we read our books, you read your books, but when we sit across, so one thing is for the fasting, as per the ADA guidelines, what we clinicians do is 8 to 12 hours of fasting. That is okay. That is so not less than 8 hours and not less more than 12 hours.
12 hours.
Actually, in clinical practice, we have a lot of patients, who come to us at 14 hours of fasting. They come fasting to the clinic at 1 o'clock in the afternoon thinking that blood test will be done, but that's very wrong. So 8 to 12 hours of fasting is considered good enough. PP is a good point because so postprandial, what we consider is the time from the first bite of the meal. So from
I want
that's
I want
where,
all of you
yeah,
to I want all of you to please listen to this line clearly.
yeah. So we calculate, the guidelines say, and these clinicians we follow, the 2-hour sample is calculated from the time the first bite of the meal is taken. So the patient starts putting the food in the mouth. That's from where the time has to be taken. There's a logic to this also, because if you go back and read about your books, like, the sight of food increases glucose levels. We all know that. The smell of food, the sight of food, and when we put the first bite, glucose secretion starts happening. And we
Insulin.
also are aware about the first phase
Insulin.
insulin secretion. So
Insulin
this,
secretion.
yes, so that also starts from the first bite of the meal. So that's, and actually some patients are slow eaters, some patients are fast eaters. So it's impossible to have a standard cutoff for all, saying you have to finish it off in half an hour, 20 minutes, 30 minutes. So we always consider the time from the first bite because that's from where the glucose secretion starts happening. So that's the ideal time to estimate the 2-hour post meal. In fact, an interesting thing, now the ADA has come up with some recommendations stating the post meal sample could be done anyway from 1 to 2 hours from the point of starting a meal. So I don't know where we are going to, but that's going to be even throwing up even higher readings and probably, but yes, the time point is from the start of a meal.
Agree with the thought process of what Dr. Archana has said. We consider it at the start of the meal, and usually meal is taken at 7 o'clock, 8 o'clock, 8:30, a particular time like that. It is also a matter of convenience for the patients to check the blood glucose level, that I have eaten at 8 o'clock, I will check at 10 o'clock. So, and some patients, they eat slowly, but when we are checking for postprandial with self-monitoring of blood glucose or the time sample that has to be given to postprandial, what we usually follow in Fernandez and the protocol, all the endocrinologists in Fernandez follow, is that we tell the patients to check the meal start time, have the meal by 15 minutes max, not 5 minutes, 6 minutes, but 10 to 15 minutes, and then go about checking the meal. This prevents that prolonged eating. Some of the patients definitely eat for half an hour, 45 minutes. They keep looking at the food in the hope that they can eat that. And they usually end up not having much after 15-20 minutes, because satiety reflexes, they kick it by about 12 to 15 minutes. So ideally, take the meal, wait for 15 minutes, within 15 minutes, finish the meal, and count it from the meal start time.
Yes, that also helps us to curtail the portion size of the meal.
So this is some concept which is quite contrary to the kind of teaching that we are doing. The first teaching that we said that most of the patients present with DKA, type 1 present with DKA, they don't. Next thing is their timing for the postprandial. According to ma'am, both of them are quite vociferous about that it is from the time the meal is taken. And the logic sounds pretty good because the insulin secretions have already started kickstarting by that, rather than waiting for the end time, which is difficult to mark. It's quite let's say contrary to the kind of firm beliefs that we hold as a biochemist in our mind, but this is definitely something that we need to now take it back to our hospitals, take it back to our clinicians, take it back to the forum, and see where we are going and what is actually the correct way to go about it. So this is a important message which I wanted to share with all of you about this. I got quite educated talking to you about this.
Actually, for fasting, just to interrupt, like Dr. Archana told 8 to 12 hours, but we have seen cases where if we take the sample before 10 hours or before 12 hours, there is a little bit variation seen in the values. If I take a sample at 8 hours, it is usually 120, 125. But if I take it after 10 hours or 11, 12, it will give a value between 90 to 100. So little bit of variation is always there. So
Yes.
we stick to the formula like minimum 10, ideal is 12.
It's not actually required. If you
8
read
would be
at
good.
least the clinicians. So it is really nice to have this bouncing thoughts, clinicians and from what the lab medicine is saying. But that's for guidelines, say 8 to 12 hours is good enough. For lipids, again, they used to be insisting about 12 hours. But again, some consensus guidelines say that you can do a lipid profile even postprandial. But that's a topic for another discussion.
That is actually another topic for discussion. When we go with the cardiologist and preventive cardiology, we're going to beat this issue over there. But again, coming back to this question about the samples, because most of the samples that we get as fasting and PP, I've got fasting samples at 6 o'clock in the evening, 12 o'clock in the afternoon, and the person says, "मैं सवेरे से कुछ नहीं खाया है." You have people say that. Okay,
Yes,
you have that.
very well agreed to that.
Okay. Chai biscuit खा लेते हैं, that is not considered as fasting. I mean, that's considered as fasting. Chai biscuit doesn't come into the equation of stuff. So in this case, I have 2 points to do. One is that if I would have use a very conservative estimate, at least 40 to 50% of the fasting and PP samples that we are generating are not properly timed. This I can say it from my personal experiences in the lab. So how do you manage patients' reports when it's actually wonky? And the second thing is, quite often than not, in the health checkup packages, I have found that the PPs are lower than the fasting. I'm not just talking about 10, 15 milligram per deciliter. We say, okay, there are a lot of other issues. Fasting is 90, PP is 60. I mean, I have actually got on to phoning up a guy at a plasma glucose of 55, and my technicians were saying 50 के नीचे critical alert होता है. I said 50 or 50 में फर्क नहीं होता है. Phone up and give a critical alert because this value is low. So what happens in these cases, and how do you actually kind of react to them?
Nalini, you want to take this? And then we both can give our inputs.
Yeah.
Yeah, it's a very, very intriguing factor that PP is lower than. We often think that PP should always be more than that, more than the fasting value, but there can be several reasons. First thing is disease-related reasons. Second thing is the patient-related reasons. Third thing is laboratory-related reasons. If we classify them into these three groups, what we can say that is sometimes in the early phases of diabetics, there is a delayed first phase response of insulin release. Insulin release happens in 2 phases, the fast, quicker degranulation phase, and the second phase wherein it is produced much more consistently but slowly. This is usually seen a little around 2 hours past, around 3 hours around, but sometimes it can be seen as early as 2 hours. So when we are looking at PP value, maybe early phases of diabetes where there is a delayed first phase response of insulin secretion, we can see PP as much lower, significantly lower, going to the extent of hypoglycemia also. So when you're talking about a disease-related factor, this is the first thing that we have to think about. Second is patient-related factors. Often when the patients are going in for a health check, they're worried for many reasons. Be it a genuine worry or psychological issue or whatever, that many of the patients are going, they know that they're going for a PP value check in the health package, and they are going to have a very different breakfast than usual. They are going to exercise much more than their usual, and they're going to exercise robustly. So the amount of food intake and the exercise don't match, and they can land up at acute hypoglycemic episode. Third thing is wrong labeling. The patient's bottle may be differently labeled for the PP. It may be somebody else's. So that may be a laboratory related issue that can happen, which can cause this kind of an issue. Or the sample may not be mixed properly because it's a health package. They're doing any number of tests. The collection sample is used. Probably the technician messed up in mixing up the glycolysis inhibitor. So that can also happen very frequently in healthcare packages because we get to see in the clinics reports, 90 reports, 120 reports that are generated. Imagine the number of samples that have been drawn, the amount of sample that has been drawn and pushed into various tubes for mixing. Probably an error can also happen out there by the technician. So if we consolidate these are the 3 major categories that I can think of. Archana, do you want to add anything?
Yeah, I think that's very succinctly put, Nalini. And I think if I looked at your 3 points, I would say the first one, the third one, the wrong labeling probably would be one of the leading causes. Reactive hypoglycemia, what you talked about, I think, when we see readings, postprandial readings of less than 70, reactive hypoglycemia should be probably the first thing to come to our mind. And especially now, given the context that, the laboratory technicians call the patient after they have finished the meal, which is a good half an hour, and health checkup packages generally serve a carb-rich meal. So,
Correct.
if they've eaten a
I really buy
carb-rich
that.
meal and we check the samples after they've finished their breakfast, which is like, you can count half an hour for that, 20-30 minutes. That's typically the time for a reactive hypoglycemia, which is commonly seen in the early pre-diabetes phase, where, patients generally say, just hungry, and they eating a lot. So that is probably a subtle sign of reactive hypoglycemia. And of course, one other point which I have to put it is, we get these people who come for fitness, fitness to fly, fitness to drive, and, the aviation industry, the sailing industry, where they need a good blood test, for
Certificate
allowing them to
be
get
able to.
carry on with the duties. So many a times we find these patients surreptitiously taking their medications and coming, or probably just eating a high protein and a zero carb breakfast. So all these things also to be kept in mind, when we interpret the postprandial readings.
So the major take-home messages which I get over here is that probably we are trying to deal with people who are going to reactive hypoglycemia, which would be a cause for this. We're picking it up at 2.5 hours where it's actually kick-starting. So the theory of sample to be timing to be at the time of starting the breakfast or end of breakfast, that debate further carries on with this point. Ma'am, the point over here is, if this patient comes back to me tomorrow, generally this creates a bit of an unpleasant scenes in the lab and people come fighting कि तुम्हारा lab तो खराब है, तुम्हारा result खराब हो जाता है and all that stuff. Is there, you do it the next day, you don't get the same results. And that
That's
really,
true.
and
That's
really puts
true.
you back in the back picture कि कल तो किया था तो ठीक है, yesterday your report was bad.
So
But
they won't do a second health checkup package. The next day they'll just eat normal food and come.
Ma'am, here it comes in the, is there any test you can do on the sample, let's say the insulin levels or something over there that can kind of protect me? Because he comes the next day, the results are all right. He says the previous day you guys goofed up and now you're covering it, and that's exactly what they need to exercise their vocal cords.
Yes. So if you looked at reactive hypoglycemia, at that point of time of the hypoglycemia, the critical value sample, though hypoglycemia, if you define it as Whipple's triad sugar should be less than, glucose level should be less than 45. At that point, it becomes the insulin and the C-peptide levels become interpretable. So at glucose levels of 60, 65, the insulin and C-peptide are not really standardized. But one thing is, probably you can do an insulin level to see if there was any hyperinsulinemic hypoglycemia, which again would, hyperinsulin hypoglycemia or hypoinsulinemic hypoglycemia, which might help. But typically, we should ask them to eat a normal food, not overload with the carb-rich meal. We should ask them to eat a normal food and come back to us, and do it at that time, within 2 hours.
Yeah, maybe what I would say is I'll agree with Darshana here, but here sitting down and talking to the patient, even before the patient says anything, we need to sit down with the patient, take a nutritional history of both the days, and quiz the patient about how the days were different on both the days. Taking a strong, solid history here often and explaining the patient all the factors in a systematic fashion and how you cannot replicate one from another, not being judgmental about just the laboratory values and not blaming the lab at the same time, not blaming the patient. Maybe we need to be wider in our probabilities of how it can happen, and explaining the same to the patient. Maybe it's time consuming, but probably the most rewarding way.
You don't know the wolves when they come and howl at you. I mean,
No,
they'll howl at you in a different axis. But the only immunity package which I have when I deal with my patients is when I can dogmatically prove to them that this has happened because of this. Okay, and here's a situation where the sugar is 60. The point is, I find that many of the time they want to make an issue out of it so that they can get mileage.
No, they just want a free bill.
They want a free bill. Okay, that's the
it.
point. That's why they wanted the mileage. And if I don't have anything to prove, like, okay, this is that, let's check the insulin. The insulin is also high. This proves my hypothesis. That doesn't work. And that actually keeps us very vulnerable. And this happens in the health checkup packages where they play a bomb. Okay, then the problem starts. Anyway, now, again, carrying on this story ahead, I had a patient has come to me in the health checkup. Let's say do you look at fasting or PP, or do you look at fasting and PP? Like, how does it go? Any one of the criterias above will be good enough, or you have, because now we don't do a repeat. Ideally, the ADS says that you should repeat it. If one value is about, call him the next week and repeat it, but I don't think that's happening. So you're looking at both the parameters or just one of them? And if I say that there's a patient who's come to me with a glucose of, let us say, fasting of 132 and a PP of 160, what are you going to do with him? How will you label
Look
him?
at so in that scenario, that's quite often seen in the clinical practice when people come with the reports. Then we need to look at the whole picture. It's
Okay.
always the whole picture that is important. We start with the family history of diabetes, how the BMI is, and we also look at how HbA1c is, how the lipid profile is, especially the triglyceride factor, how it is. You see all these things, and then go towards where the evidence points the most. What do you think, Archana?
Yes, I agree with you. It's holistic, and each one of them has their own importance. Fasting has its own place, post meal also, and the A1C also. All three of them independently do stand up for themselves.
Okay.
So as
the
a
next-
screening, you can use random blood glucose. Then we
Just
can go
screening.
for.
Screening. Yes, only screening, but not diagnosing.
Not diagnosis.
So okay.
Now comes the
And
now comes the next dimension. A 35-year-old person presenting with genital
blood sugar 380.
genital lesions and got a sugar done 350, got an HbA1c done 11.5. Now, in this scenario, how are you going to what are you going to advise for further workup, and what is the treatment of choice?
We are taking, okay. So he's a young male, just with genital infection, no
Yeah.
other osmotic symptoms,
No.
and a glucose level which is 350 and A1C is 11% plus. So, the first thing at that age, what will still be the diagnosis in good chance is type 2 diabetes. But the way he's come up at this age, he's still young, and he's lean, normal BMI. And with such high sugars, we need to rule out the autoimmune type of diabetes, which can still present at this age. We talked
Okay.
about LADA, which is latent autoimmune diabetes of adults, which is a slow evolving process, autoimmune mediated process, typically happens after the age of 30. Also look into whether there's family history. But still, family history is more towards type 2, whereas LADA would be typically in this presentation. So in this young man, I would look at, we should be asking for a insulin C-peptide and the GAD antibody.
Insulin C-peptide GAD
GAD antibody should be
The
done
other
in this
cocktails,
gentleman.
the other cocktails of antibodies, islet cell antibodies, insulin
Good
antibodies,
question.
IAA, ICA.
Yeah. So if you look at some of these labs offer a package of antibodies. Now, the commonest, which is easily available in most places, is the GAD antibodies, which is glutamic acid decarboxylase antibodies. Now, these antibodies are more commonly seen in the adult immune in LADA population. It can be seen in children also, but more in the adolescent and the the elderly teens as such. The other antibodies, which are the islet antibodies, the IA2A antibodies, and the zinc transporter 8 antibodies. So these are newer antibodies. Insulin auto antibody that can be seen in the younger children, and it's seen in the earliest phase of newly detected diabetic, but it's a very short living. I mean, it gets washed out after a period, after a few years. Whereas GAD is the opposite. It comes up a little later in life, but it stays for a longer time. The other antibodies, which is your zinc transporter antibody, it's a marker of a rapid progression of the autoimmune diabetes condition. And the IA2A antibodies indicate a more aggressive nature of the condition. So we can do. So it's said that if you have two antibodies positive, there's a 70% increase in chance that the person is going to be a diabetic in the next 10 years. This is, we're talking about siblings of type 1 diabetes. But in this young man, But to put it in simplicity, in this young man, 37-year-old, we would just do a GAD.
So
So
just
you wanted to
to,
ask something?
yes, just I wanted to ask Dr. Archana, like if C-peptide is helpful in diagnosis in such cases, in a LADA and any other things. So why C-peptide is not being prescribed that much? Because we see very less prescriptions of C-peptide. Like it is a subject of interest since 2000. Like when I did my PG, my thesis topic was on C-peptide. Now it's 2025, almost 25 years. The topic is being discussed, but the number of prescriptions what we see for C-peptide in terms of investigations required for diagnosis or prognosis is very less.
Absolutely.
I
That's
used to have it in my.
fabulous question.
I used to
Fabulous
have it.
question.
I used to have it in my menu in Vedanta, 5 years and maybe 4 samples. And running the test was more expensive than maintaining the
Running the
test was more
marathon.
expensive than outsourcing it. That's what happened.
Yes. So basically, C-peptide and insulin have very specific roles where we actually use them as endocrinologists. C-peptide indicates the reserve of insulin left in the body. But C-peptide, when we look at diagnosis, it's not low or normal or high. It's either normal or low. If it's low, well, it tells us about compromised insulin reserves. And what is low? If you look at nanogram per ml, it's 0.6 nanogram per ml. Anything less than that indicates a low insulin reserve. But if you have somebody with a sugar or glucose level of 370 and a C-peptide of 1, which is normal, right? But still his glucose level is 370. So there is some insulin compromise which is happening there. Maybe it is glucotoxicity, maybe it is type 1 diabetes, autoimmune insulin deficiency which is there. So a normal C-peptide level will not give us any additional information. So for a diabetic, for a person who is already a diabetic, he's on multiple medications, to use the C-peptide as a guide to start on insulin therapy is wrong. Because a normal C-peptide is not going to be reassuring with a glucose level of 370 to say that this person doesn't require it, which is wrong. At the same time, a low C-peptide, this gentleman has a glucose level of 370, and he may have a C-peptide newly detected diabetic, and he may have a C-peptide of 0.5, which is low. But this could be a very well, and antibodies are negative, insulin levels are borderline. So again, this is like an insulin level of less than 3 is normal. I mean, less than 3 is low, and more than 3 is normal. So a normal insulin or C-peptide is not a foolproof parameter of insulin resistance. A low, yes, it does tell us there's deficiency, whether it is absolute or relative. Time will tell us glucotoxicity phenomenon has to be ruled out. So where do we do C-peptide and insulin? It is these newly detected diabetics where we are not clear whether it's type 1 or type 2, whether it's type 1 or 1.5, which is LADA, or type 2. There's still a diagnostic dilemma. Suppose if this 37-year-old male was a little overweight with a BMI of 26 and there was a family history, but he's come to us with ketones positive and glucose of 370. So it could be type 1, which is LADA, or it could be type 2. So in these cases, it's where C-peptide and insulin is going to help us. And in non-diabetic hypoglycemias, where we're looking at insulinomas, that criteria, or if it's a drug-mediated thing, surreptitious use of insulin, that's where these levels will help us, but not in a routine diabetic to decide the need for insulin as therapy.
I missed one point. Insulinomas, C-peptides will be high.
Yes.
Okay. And
see, much more than hyperglycemia, it's hypoglycemia where C-peptide role comes in. Because just because a person has normal C-peptide doesn't drive the way we treat this particular patient when it is hyperglycemia. But it tells a lot about hypoglycemia when we measure the C-peptide level. Why? When a patient who's type 1 diabetic is coming to us with recurrent hypoglycemia and recurrently low requirement, do we think about honeymoon phase, that is temporary improvement that is happening? Or do we think about surreptitious insulin intake? Our question hangs here. If the C-peptide level is normal or increased, then that means it is honeymoon phase. If the C-peptide is undetectable or very low, this indicates that the person is taking a lot of insulin from outside, and that is the reason why we are not able to measure C-peptide. So
Yeah,
hypoglycemia C-peptide is much more useful than hyperglycemia, and our way forward is not clear if we measure C-peptide in hyperglycemia.
Okay. Right. Good understanding.
that
And to add on for this, like for insulin, nowadays we are seeing more prescriptions for fasting and postprandial insulin, which is like written rampantly. So why it is being advised more, and like what is the purpose for having, is it like a good prognostic marker or a good diagnostic marker?
My God, I really love the questions you guys are putting up. So practical, so relevant. Thank you for this, I should say. So I completely agree with you, Dr. Suhas and Dr. Arun, that we are seeing a lot of insulin prescriptions, and it's not just fasting insulin; it's postprandial insulin.
Postprandial also.
They do a OGTT and they do a fasting glucose, fasting insulin, 2 hours glucose and 2 hours insulin, which is like we don't need the insulin level. So one point is we are seeing a lot of people with metabolic syndrome, which is basically dysglycemia, hypertension, dyslipidemia, central obesity. And as a part of this metabolic syndrome, PCOD is again a very common condition. And typically, if you ask me, I have seen a lot of these insulin prescriptions for girls with PCOD. Now, one point is insulin level. As with C-peptide, insulin level, there is no cutoff. It is either low or it is normal. There is no cutoff to say that it is high insulin level. So if you look at the traditional reports of insulin, it's anyway written between, I think, 6 to 25 is written as the normal insulin levels.
Yes.
So that insulin resistance is clinically measured. Now, what do you mean by clinical measurement? It's the weight, the body mass index, the waist circumference, and clinical markers like acanthosis nigricans, which we all know is thick, dark, velvety skin and all skin folds. Typically, we see it at the nape of the neck, we see on the knuckles, underarms, and all that place for flexural areas. So these are the clinical. So if I have somebody who walks into my clinic overweight or obese with acanthosis, I know this person is insulin resistant. And doing an insulin level is not going to add any more to my knowledge. I would rather measure the outcomes of insulin resistance, the fallouts of insulin resistance, which are all in metabolic conditions. That is PCOD, diabetes, dyslipidemia, fatty liver, hyperuricemia, hypertension. These are all the clinical outcomes of metabolic syndrome or insulin resistance. It's more worthwhile to measure these parameters than going after the insulin level. What do you say, Nalini?
Absolutely agree with you with every single word. Every single, nothing more to add. You put it perfectly well.
So now
So
it's
that's it.
crystal clear for us.
So that's a 1 point note for everybody who wants to start insulin in their lab. A clear-cut message. Okay, we've had a lot of talks about the antibodies and we've had a lot of talk about insulin C-peptide. It was really eye-opening. So now let's come to the regular bread and butter kind of a talk. And that talk is about glycated hemoglobin. Dr. Suhas, could you tell us about the various methods of glycated hemoglobin like ion exchange, boron affinity and all that? Is there any differences between the these methods?
So the most preferred method for glycated hemoglobin is HPLC, as you know, extensively used because of the sensitivity and the specificity. Earlier homogeneous assays were there, which are now not that much in use. And POCT, the variation in the values is too high. So for me, as a lab personnel, I will feel HPLC is the best possible way to go forward and do the analysis for glycated hemoglobins by HPLC. And we give the results in the form of graphs, which the clinicians will also interpret. Like
Yes.
if they have an HPLC graph, they are also sure whatever result has been given is 100% correct. Whereas for POCT and for homogeneous assay, it will not be available.
I have a different take on that, but first we'll take ma'am's opinion on this thing. When you get an HbA1c graph and you get a variant peak, how do you actually interpret this and how do you actually manage these patients? Because there could be a hemoglobinopathy, let's say HbS or an HbD, How does that actually help? Because then the HbA1c values don't actually correlate with the glycemic control.
Yeah. So one thing,
Go ahead, Archana.
no, a few cases is probably, the ethnic where they come from. So many people from Northeast do have some variants in the hemoglobin, which can interfere with the assays. That's one. And people with sickle, thal, there also HbA1c becomes a little
Lower than normal because of the shorter span of lifespan of the
correct,
RBCs.
correct, and becomes difficult to interpret. Other conditions where I feel probably is, the patient has received a recent blood transfusion, or there's been a massive blood loss, a significant drop of hemoglobin in just a very short time of maybe a few hours or so. There also, we may not be able to interpret the HbA1c properly. Sometimes some medicines like vitamin C or aspirin in high doses.
Yeah, they can interfere with it. So the question is, supposing there's this thalassemia. In that, if you have to check up the glycemic control where HbA1c is not good, what would you do?
So I would rely
Redefine
more
the goals or go for other markers.
other markers.
Like
I would like glucose, fasting and postprandial glucose, and I would look at glucose points through the day, not just a post lunch. Probably look at post breakfast, post lunch, and post dinner also. What would you say, Nandini?
So I would say we can also think of fructosamine, anhydrous glucitol, glycated albumin. Even though the cutoffs are not there in our population, probably these are also good alternatives because fructosamine gives us about 21 days of values. How did the patient fare in past 2 to 3 weeks? At least we know certain data over the past few weeks how the patient has fared. So this is not dependent much on the hemoglobinopathies because it's just not related at all. So fructosamine is one option that we have. Next we have is glycated albumin. Again, specifically measuring glycated albumin, not every lab can do that. And it gives a shorter term because albumin life is about 5 to 8 days. So shorter term assessment, only probably about a week's worth of assessment is what we can do when we see this. And then we even have glucitol. When we measure glucitol,
anhydrous glucitol, yeah. By anhydrous glucitol, yeah.
Yeah, anhydrous 1,5-anhydrous glucitol. When we are measuring it, the big problem with this is, I think there was one study, Omnicarb study over something which was done in maybe 5-6 years back, wherein they showed that even though they say 1,5-anhydroglucitol doesn't much change, it varies because several food substances which are commonly used in India, they have this substance, and because of this dietary intake, there's a lot of variation based on the consumption. So when we're measuring something which we take very often in our diet, it is liable to change, and also it depends on the renal function because it's 100% and freely excreted by the kidneys. Completely, when there is a CKD or an AKI situation, the levels are bound to be disturbed. So we have other markers, but what are the cutoffs in our population? We still don't know. Are they universally standardized? Not yet. Are there limitations existing? Yes, there are limitations existing. Even for albumin, when we talk about if there is a case of MASLD, that is a fatty liver and then subsequent liver disease, definitely albumin levels and glycated albumin levels are going to change. So all these factors, they tend to put each and every alternate marker at a disadvantageous position. But then in hemoglobinopathies, the most practical way of checking and easiest way of checking, as Archana says, is go in and see the blood sugars. Maybe have an SMBG chart.
Do you have a redefining of the target goals? Like, okay, this guy is a thalassemic. This is, instead of setting the target as 7%, do I redefine it as 5.5% as the target goal? Do we do something like that? No. I'm just talking theoretically.
Nothing come up as yet because I think that itself is very dynamic and lot of interpersonal variations.
Okay, so that now there's another interesting thing because when you talk about homozygous hemoglobinopathies, even for conditions like HBC, HBE, which doesn't totally affect the lifespan of the RBCs, and it doesn't cause, many of them go HBD, they don't even know that they're having HBD until they're way past 70s and 80s. The HbA1c cannot be detected because of the inherent analytical techniques. You use the immunosystems because the antibodies don't bind, you don't get a quantification. HPLC, you require HbA to centralize the chromatograms before you can take the reading. So when you have a homozygous hemoglobin variant, none of the systems work. How do you manage these patients?
SMBG monitoring, CGMS monitoring. That's all.
Okay, so in these conditions, you fall back to the good old plasma glucose and either by the glucometer, and very good. Glucometers are subjected to lot of variations and pre-analytical errors. Even in the hands of the nurses in the hospital, we don't get good readings. How do you teach your patients to take good readings and how do you manage them?
Education.
Yeah?
Education.
No, but then,
Education.
is there any kind of I mean, how do you say that? Like, do it in front of me and show me how it is being done. Is the results correct? Because you press more hard and get tissue fluid and your results go wonky. So I find that
No,
very difficult when
it's very
everybody
important to have
won't
an educated nurse.
Yeah?
It's
No, I'm
very
talking about the
important to
patient.
have an educated nurse. Diabetic
Okay.
nurse or endocrine nurse makes a difference. The usual nurse is different. A diabetic nurse is very different. A diabetic nurse tells the patient, even in India, the concept is there, and we have diabetic nurses, wherein we train these nurses specifically on how to use the glucometers, how to check the blood glucose level value with the glucometer, and how to close the loop of communication. The closing of loop of communication with the patient happens only when the patient demonstrates back without any error how to check. So getting standard correct glucometers, at least data of the glucometers of which is published, is first important, not any random glucometer. Second thing is measuring properly, as you've rightly said, we need to wash the hands very well, dry them completely. There should
Dry
not
them
be
is a
any
very
trace of
important word.
Yes. And then we should dry it very well. We should avoid any residue leaving cloth or tissues when you are drying it. It's very important to tell all these seemingly unimportant and minute aspects because all these play a role. There was once a patient who's come who said that I checked in my index finger, the value was 250, and then I was really upset. I checked in my ring finger, the value was 95. I did not know what to do. Then
This
you
is
need to
exactly
tell,
what this is exactly what I'm saying. This is
it's
exactly
the
what
same patient, it's the same within 5 minutes, and the value is this different on a standard glucometer. Because we often avoid index finger because we use this finger for touching everything. The patient apparently had touched something, did not wash properly, and then checked with the glucometer, the reading is sky high. Now she hasn't used her ring finger anywhere. So it's important on which finger we are checking, how we are squeezing the blood out, where we are applying the pressure. All these things are very important when we are doing the glucometer checking.
A more important thing which is usually missed out becomes very important in places like Delhi and North India. Warm the finger before pricking
Yes.
it. Otherwise, the fingers have got it's dried up, and then you just take a prick. You don't get blood, jump, and all the tissue fluids have come outside. One of the audiences asked a question that glucometers are not reliable in hypoglycemia. Any experiences on that?
Plenty. Archana, you want to take?
No, they are not reliable. In fact, the CGM is even worse in terms of hypoglycemia. So whenever we have a low glucose level on a glucometer, we always ask them to recheck it a couple of times, and if possible, if the patient is admitted, send a lab sample. So that is one thing, but still they are better than the CGM devices for hypoglycemia. But again, the pre-analytical things like spirit, interference of
I
spirit.
think we are extending the 1 hour tenure. We are extending our hospitality. One last passing shot before we close up the day, because this is a ocean. We can have 3 more sessions on this. You use the word continuous monitoring of blood glucose, which is the biggest fad right now. So does everybody go with that patch, or the glucometer is still good enough, or do you rely on yours truly neighborhood doctor's lab to do the plasma glucose?
Yes, circumstances, Nalini, take over.
Glucometers is the first choice because of multiple reasons. Ease of availability. The control is in the patient's hand. They can check it themselves. If something goes wrong with it, they'll get a new strip based on the error message that is given in the glucometer.
तो
So
हमारे पेट
glucometers
पे
are
लात
less
क्यों मारते
expensive.
हो? हमारे पेट पे लात क्यों मारते हो?
And then second thing, because it's in the patient's control. Patient's control. And when we are dealing with something as acute as hypoglycemia, even though glucometers are not sensitive, they give us rough idea where we are heading to. So a level less than 70 should alert the patient and should make them check once more and then take a carb rich meal according to the hypoglycemia management even before the critical level of 54 happens. So glucometers always are important to check first thing because of these reasons. They are bad because the sensitivity is not there. Sometimes the storage technique is really bad and checking technique is also very bad many times. So it's important to understand that all three, be it self-monitoring or CGMS or the laboratory, all of them have their own shares of negatives as well as their own shares of good things like CGMS. CGMS is a boon for type 1 diabetic. But for a non-diabetic who's wearing for a fat, does it offer anything? No, not much. It's become fashionable, especially in certain elite sports category where they are just wearing. But what is their purpose of wearing? They are not looking just at the blood glucose level peaks and everything. They are looking at their exhaustion peaks. They are looking at their performance peaks. They are looking at how their mental abilities are to take a decision in that split second, especially when we're talking about cricketers and runners and things like that. They're looking at all these factors holistically and how is it changing. So that is what they've been doing, even though in non-diabetic elite sports person. Unfortunately, they have set a precedent wherein anyone can wear glucometer and it doesn't give anything. Right, Archana?
Yes,
Right.
yes, I agree. Yes.
Nowadays,
That
it's
always the gold standard.
Yes.
nowadays it is used more for making Instagram reels.
No,
You will be
Nalini ma'am,
you
you
will be
had a very
having they will be having a CGM. They will have a specific diet. They will then tell what is the peak by having
CGM
breakfast of
is good. There's no doubt about it, but it is used in very niche population. As Nalini said, type 1 definitely a life changer, game changer. Type 2 diabetics who are on multiple dose insulin, it helps
Yes.
them because they get away with the pricks of the multiple pricks daily. And maybe the newly detected type 2 diabetics who they are very aggressive about lifestyle changes, they get to see how the food changes with how the glucose peaks happen with different foods. So they make their changes accordingly. So in the people who are looking at diabetes remission, it probably can be a good aid for a short duration. But
okay.
no.
And to allay the fears of Dr. Arun, like recently he told, na, mere pet pe kyo laat marte ho? There is a specific question from the audience in terms of what is the major reason for increasing the number of diabetics globally and in India?
Yeah.
So
I
it,
found some changes occurring post-COVID also. What's about that? You got a good point.
In fact, COVID was a big thing which came up because post COVID we've seen many newly detected new onset diabetes. So there are published papers on that whether COVID induces beta cell damage, islet cell damage. COVID can induce autoimmunity, antibodies. It can worsen insulin resistance in pre-existing diabetics. It makes them more go towards insulin. So yeah, the reason for increase in diabetics worldwide, it's the pandemic, the twin pandemic of obesity and diabetes. Of course, stress, lifestyle, environmental pollutants, the endocrine disruptors, reduced sleep. These are all the newer pathogenic, mechanisms which are sort of incriminated in the boom of diabetes, metabolic disorders which is happening.
Ma'am, you got anything to add on to that?
I'd say that availability of avenues to change the lifestyle are also the major culprit. Earlier, maybe a decade ago, also we did not see so many restaurants outside, so much of market for a high calorie food. So that also is paving way, wherein a non-essential item, because of hedonic hunger, they're also having it. The socializing pattern has changed definitely in metros. So the way of socializing is to eat outside much more than eating at home. So that lifestyle pattern has definitely changed in last decade, especially so post-COVID, where probably people felt repressed over all those staying at home situations. They are going out much more.
So any of the preservatives, food preservatives playing a significant role?
More than preservatives, I think it's the chemicals which get added, hormones and those BPAs, bisphenol
Okay.
acetates, lead. There are a lot of EDCs, which you call it as endocrine disruptors, which induce insulin resistance. So,
Okay.
food contamination is a definite risk, a risk factor for all this insulin resistance, worsening insulin resistance.
Yeah, in addition to it, the emulsifiers which are often added to the foods. There's a Lancet study that has come out which says that these emulsifiers, certain of them, they predispose an individual to type 2 diabetes much more.
Okay.
I think the message is loud and clear to all the audience. Eat good, healthy food, stay
Homemade.
healthy, and
Homemade.
stay away from diabetes. Thank you very much, ma'am. Thanks a lot. I mean, this discussion can go on and on and on and on, and I'd still love to have it. But thank you very much for sparing your time, sparing your discussing with us, opening our eyes to certain new things. We need to look forward to it. Thank you very much.
Thank you for
Thank you. Bye.
making me a part. It was actually fabulous questions, and I enjoyed every bit of this last 1 hour. Thank you so much.
And a big clap
Thank
to
you so
all
much for
these
having me here.
audience. And a
Yes,
big clap to
thank
all the
you.
audience for having been glued on for this entire 1 hour listening to it. Thanks a lot. The
Yes.
recordings of this session will be put in our ACC LMP website. We can, for those who missed it, we can watch it there also.
Just a suggestion, Dr. Arun.
Yeah.
Arun, we have so many questions in the chat box.
Yeah.
So if we can give some specific answer down the line, we can share it with the concerned participants. It will be informative for them. Some important questions are there. We can exchange and we can